You will present your case, and then we'll have discussion. Okay? But nice discussion, okay? Try to be nice.
We have the slide. Thank you very much for both lectures. It's very, very important. I'd like to present the first case. I think it's a very straightforward case. And the real question is a gut feeling question, actually, because we are in stage 2 very, very motivated by gut feeling decisions because we lack evidence. Like any situation in which we lack evidence, we're motivated by gut feeling. So this is a 40-year-old patient who had a stage 2, very classic T3 and 0. There was no lymphovascular invasion. We don't know about the perineural. We didn't have that information. 28 lymph nodes were examined. None of them were reported to be involved. There was grade 1, no obstruction, no perforation. Clinically very low risk patient, but 40 years old. Obviously, we did an MMR status within the oncotype. We can receive the MMR, which is a very good step for us in any event with young patients. So we like sending them to this test anyway. Because we get it for free like that. So that's the score that we've got. Any ideas what we decided to treat? Oh. Maza. Okay, so we decided to not to treat, but any other suggestion for this 40-year-old patient? Would anyone have treated that patient?
Absolute benefit.
That's why I'm asking. I'm asking. Yes.
So.
But not with chemotherapy, I hope.
No, sometimes with chemotherapy, yes. Breast cancer patients, 3%. You have patients who will have questionnaires. What size of benefit would you accept? And it starts from 1%. I think somebody. I think
there's a study like that in breast cancer. It's true. We still don't have the study in colon cancer.
Yeah, but it's 40-year-old. That's the difference. I mean.
Okay, so you would have treated this patient?
I would give her Exceloda. Yeah, why not? It's a very simple drug. But I'm not
Anyone else? It's a 40-year-old patient. That's why it's not a trivial. It's not a trivial case. That's why I'm saying that we're fighting our gut feelings here. Another 0.5%. Anyone? Baruch?
I thank you for the case because I think it emphasized something that I wanted to emphasize and I forgot. I think that the benefit that we have from this kind of tests are not only, as I mentioned before, to treat or not to treat, but sometimes if you want to give less cycles or so on. I would clearly treat this patient. I may even consider oxaliplatin, by the way, because she is clearly high risk stage 2 colon cancer by the clinical, by the traditional features.
Which traditional features? There is no obstruction, no perforation.
Age.
Age is not one of the. Age is not a clinical condition.
Sorry, but let's go back to the old studies, to the Mosaic, which is still the cornerstone study in adjuvant treatment of colon cancer. In the Mosaic, there was in the 3-year disease-free survival 7% absolute gain in patients that answered to the 4 or 5 features that defined high-risk patients, and one of them was age younger than 50. And clearly, a patient at the age of 40, you can consider, no, so you don't consider, I consider, but that's, but I consider it, I think it's good to consider. But what I wanted to say,
trying to have a civil discussion
I didn't want to refer to the question of oxaliplatin because it has nothing to do. maybe it has to do with the test, because we saw over there the high risk stage 2 in the NSABP CO7 study, and over there the definition of high risk stage 2 was included also age, by the way. It was very similar to the Mosaic in that sense. But let's just stick now to the 5-FU-based or Xeloda-based chemotherapy. I think these studies also provide information of how are you going to insist on the treatment. So I may start with the treatment, and when the patient has significant difficulties or toxicities with the treatment, it may help me maybe with the decision when I'm going to stop the treatment, after 1 dose reduction or 2 dose reduction, how I'm going to be rigid with this patient and to encourage her to still continue and to complete the 6 months of treatment, or whether if I know that this is the result, maybe after several difficulties, significant difficulties with the treatment, I would just discontinue the treatment.
So we have 2 treatments here. Any observations? And show of hands? Anyone not treating this patient? You would like our guest to say something? Yeah.
Certainly, I would sit down with the patient and have a discussion with the patient, saying this is your risk of recurrence. This is the absolute benefit of going through treatments. This is the side effects of treatments. I would think that the majority of my patients would say no. There would be some patients that would say yes, as long as they know the benefits and side effects. I also put it there's another way of putting it. You have 100 patients, and if you were to treat 100 patients, you wouldn't change the outcome on 98 of the 100 patients. You would only change the outcome on 2 patients. So I would have that discussion. Some of my patients would say yes, most of them would say no, and if they asked my opinion, I would say no.
Okay.
No?
No, because
Last word? Yeah.
No. All I was going to comment is that before we discuss it with a patient, we have to offer our opinion. It is not a decision. I mean, we should say we recommend this, we recommend that. These are the data. You can be part of the recommendation. I don't think it's a hard decision for us that the patient should decide. We should always come with a recommendation.
So just to summarize this case, it is a very interesting case because with young patients we tend to have a lot of fears about not to give treatment. I have to say that the recurrence score here did make a difference. I think what I view, the way I view recurrence score is more for the discussion with the patient than for the actual decision that the physician gets, because my true belief is that in stage 2 colon cancer, since we lack strong evidence, it's a very patient-motivated decision. So I fully support the situation in which we discuss the patient's result. The numerical figure that you get in the recurrence score allows the patients to feel a little bit more the chances. It makes him feel a little bit more confident on what we're talking about. And I have to say that I've discussed this with this patient, and we opted for observation, and I fully supported that decision, I have to say. Because I don't know, you don't know my boss, but everybody else here knows him, and I've grown under his supervision. And as he says very smartly, even though the patient is young, it's not a reason to punish him twice. So thank you very much.
Thank you so much. I would like to make a comment as well, if I may. This is the beauty of recurrence score, giving a continuum risk of recurrence, and as Professor Brenner mentioned, individualized risk that you can use with other factors, and this case actually emphasized this. We'll go for the next case by Dr. Purim will present it.
כן, בסדר, זה, עכשיו בסדר, לא בסדר, זה משהו, לא, זה, השני.
Please try to be polite, to listen to your friends.
Good morning to everybody. In contrary to my colleague, I would like to present a more usual case that we almost meet every day. There is a 64-year-old female that was presented with a T3N0 adenocarcinoma of the colon. As you can see, we don't have any high-risk features, no lymph vascular invasion, no perineal invasion. The MMR was proficient, and the lymph node was adequate. It was 15 lymph node that was removed, and the histological grade was 2, and she was offered to do an oncotype colon. As I was raised under another boss, we claim to treat most of our stage 2 patients, and we are criticized for it. So if we didn't have this oncotype colon test, I would suggest to this 64-year-old patient that was otherwise healthy, I was offer adjuvant treatment. And as you can see, the oncotype, the X colon was supported my decision, and she was having the recurrence score of 45, so it was 19% of recurrence score, and she was offered to start adjuvant treatment with Xeloda, and she finished the treatment about 1 month ago, and currently, as you can presume, she's disease-free, but we wait for the 3 years to prove if I was right or wrong in this patient. I suppose that some of our colleagues will not treat this patient if she will not have this high recurrence score. Do I right, Professor Aderka?
Why should you give treatment to a patient whose scores, all the scores are negative, and you have to give her such a high toxic regimen?
First, I don't agree with you, Dr. Schneer. It's not a high toxic regimen. It's not AC followed by T. It's only Xeloda or 5-FU. No, I don't agree with you. It's not toxic. Professor Brenner, do you have a different opinion?
I have a different opinion about the toxic, high toxic term. So you can give a 5-FU, Roswell Park, if you don't like Xeloda or something like that, which is better tolerated according to some people's opinion. But you cannot consider this kind of chemotherapy as high risk or high toxic or
high
whatever.
Toxic. Okay, we make a vote. Who will treat this patient according to the risk score? Who believe in this risk score? I think the majority. I'm not the speaker of the Knesset, but it's look the majority here.
There is somebody who said that the majority is usually not right.
The majority is?
Usually not right.
But this is the majority, Professor Aderka, also in the politics here in our
I know, that's exactly what I'm saying.
The majority is not right.
Dr. Kozloff, any comments on that?
One can make an argument about treating and not treating, this is the current group. I basically, again, would have a frank discussion with the patients, but my tendency would be to treat this patient, and that would be my recommendation to the patient. But if the patient said no, knowing the risk benefits, that would be a decision they could make. I would support the patient either way, but I would tend to want to treat the patient because I think the prognosis, I believe that this test really does give a better prognosis. It's not as predictive as we would like at all, but it certainly is prognostic. I'm sorry if you disagree.
You totally fit to the atmosphere of the Israelis, for sure. Okay. So we move to the next case. It's the case is by
גם אני.
גם אתה? כמה
כן.
cases? טוב.
2 במחיר אחד. The second case that I would like to present is, on the contrary, 8-year-old patient. So we increase in the age. And this, for my sorrow, this was a 80-year-old patient that was presented again with T3N0 adenocarcinoma of the colon that didn't have any of the high-risk features, as you can see. His histological grade was 3. His lymph node, he was removed 18 lymph nodes, and his recurrence scores of 51. So 22% of risk of recurrence following the surgery. I suppose that if I will make a vote, the majority of the people here will vote not to treat him, to do observation alone. I forgot to mention, this was a dialysis patient. So I suppose, Dr. Schneer, that your decision was not to treat the patient. You will treat the patient. With high toxic regimen, there's 5FU.
Did you calculate his life expectancy? No, I'm serious. When you're treating geriatric patients, one of the major things you have to do is to calculate the life expectancy. Because if he has a life expectancy of 1 year, if he has a recurrence score of 117, you don't treat him. So I think when you have a patient, especially with major comorbidities, one of the major things you do is to calculate his life expectancies, and you have tools for that to do that.
I'm sorry I cannot answer this question because for the first period of time, this patient was not mine. Okay. I met this patient 1 year after, but the physician that was then treating the patient was discussed with the patient the high risk score, and he offered him chemotherapy with 5FU, of course. And for my sorrow, he refused the treatment. The patient refused the treatment, though the physician offered him the treatment. And the recurrence score in this case was proved to be stronger than any other features. As you can see, 1 year later, this patient presented with a recurrence with metastasis in his liver. No.
So the treatment would have not made.
So you were right. Not to treat the patient, he was recurred. You said to treat, נכון. I'm sorry. I ask for your forgiveness.
Okay. There is nothing like right or wrong. Come on. I'm not sure that 5FU would prevent his liver metastasis. Come on.
Exactly.
Maybe it would not do it, but maybe it would have delayed it. So I would be more what? No,
It could
cautious.
be
more cautious. Yeah. I would be more cautious because it may have delayed the recurrence. Because I'm sure that now, I don't know where he's been treated, but I'm sure he receives chemotherapy. I'm sure he receives combination chemotherapy, maybe a biological agent also. All of a sudden, this dialysis patient is fit for everything. So we need to be my tendency in these patients is sometimes to make more effort in preventing the recurrence or something, not to not to have to treat him afterwards with all of his severe comorbidities in a palliative setting. And we know that most of us would treat this patient in a palliative setting. No?
No.
יכול להיות? No?
I have to say that I think in this case, just like the extreme of a young patient, maybe the recurrence score can prevent us from having, from practicing ageism for both directions, because we need to decide according to the biological state of the patient and not the chronological age of the patient. So I fully support what Noah said, that we need to evaluate his life expectancy, and I tend to treat quite a lot of these aged patients, even with adjuvant treatment. I have to say that with dialysis patient, it depends. I think dialysis does lower his life expectancy quite considerably. So I think this patient probably would not have been treated and probably wouldn't have prevented his liver metastasis. But it doesn't mean that I would have treated him when he would have recurred. Because I think once he recurs, if he's asymptomatic, then we can definitely try and delay treatment as long as possible.
I agree with you, Ravit, and I see the test as a major or one of my cornerstone decision when I meet such kind of patient that are age, that I would, when they tend to age, I would more and more have a tendency to go to observation alone. And if I can select the high-risk population according to the test that I have now the possibility to perform to this patient, I can select the cases that I would suggest a treatment, and we can see more and more of this age patient. I don't speak only on this comorbid patient that are good physical health, and I think that treatment, adjuvant treatment, even to an 80-year-old that is in good condition, can avoid the recurrence, and to handle later with the metastatic disease, I think that it's more difficult to us and more to the patient itself. Ken, Professor Fenig.
This test is not predictive.
It's not predictive, prognostic.
In this case that we are very reluctant to treat, if there, and the question is for Lior, if maybe this test can be improved by putting some genes to make it from only prognostic to prognostic with predictive. This can more confident to treat a 80-year-old patient with dialysis, to give him chemotherapy. If this was on the table, maybe I will do the decision. Otherwise, if it's not predictive, even it's high-risk patient, I wouldn't give chemotherapy to this kind of patient.
Who will send the test from the first place? Case. I believe that most of you will not send for 80 years old patient.
I think you should send the test only if you plan to follow the results. So if Ofer, for instance, thought that he would, if he will get the high-risk score, he would treat this patient. I think it was justified to send the test.
But we did make a group decision to consecutively test all patients. May I remind you? So I don't know if there was much thought behind this case.
Yes, but you don't want also to, I think it was okay not to send the test for someone who it is very clearly that he doesn't want even to consider the results, because the test have to be, we have to inform the patients with the results. So you don't want to complicate the situation with the patient. If a patient says, I don't want to consider any treatment anyhow, why to send a test? And you will have to inform him that he is in a high risk. So I think it's okay. We tried to send the results, and we said that even if you're not certain that you're about to treat the patient, that's fine, send the test. That's what we meant to begin with. But if you're so confident not to treat, or the patient is really insisting that he will not do anything with the data, I think it can complicate the situation in a clinical, in the practice.
Yeah, in practice, I agree.
Yes.
I kind of agree with the group here that states that they would assess the physiology of the patient, not just the chronology of the patient, and make decisions on how healthy or unhealthy an 80-year-old is. This is a patient who's had 3 MIs, on dialysis, neuropathy, frail. There's no way I would do the test on the patient. If it was an 80-year-old who walked in the office and never had a medical problem and looks better than some of my 65 years old patients, I would. And in our practice, we have actually a geriatric oncologist, so when there is a question to things, I get his opinion before I do anything.
Dr. Brenner, for the next case, please.
Hello, I would like to present another extreme case. This is an 85 years old patient with generally good health in the background, with hypercholesterolemia, hypertension, and osteoarthritis of both knees that because of it he needs a walking stick. And he came to my clinic, he underwent June sigmoidectomy because of stage 2 colon cancer, and he had a complication after the operation of urosepsis with antibiotics and catheterization, and he came into my clinic with his 2 sons, and they spoke about his good physical condition before the operation. He was independent, he was self-sufficient and everything, but he looks in a performance status of, I think, maybe 2 or 3, not 4. But I thought this is connected to the complication of the surgery, and I thought he will recover. And because of his good health, I sent the test. Otherwise, you know, this is, I looked at the quasar scale of ages. 86 was in the end of the scale, but it was included in the quasar, the 86 years old patients. So the test is MMR proficient with a risk of 41. That means 80% of recurrence 3 years. And he came after 3 weeks again to my office without any, no change in the condition. I spoke with him, and I decided, and he decided too, that we won't give him any treatment because of his condition. But I invited him again, and I saw him 3 weeks later, and this was the same decision. I think if his situation was the basic situation that he spoke about, he will be, I would have given him the treatment. But the medical condition was make me decide this decision. What do you think about the test, doing the test, about 86 years old patient? Who would have sent the test?
How many patients like this are in the research program? Almost none.
I tell you,
Out of 1,500.
the quasar included this risk group, this age group. And 86 years old patient can be, we spoke about 80 years old. 86 can be better than 75 years old sometimes. No.
I think, Ronen, first of all, it's not surprising that this was your practice.
Yeah, I came from the same.
Congratulated for it. I think that if you consider the patient's medical condition as related to the recovery from surgery, and it may change, and you consider that in his baseline you would have treated him, then I think sending the test is justified. And again, age, today we should consider age, I think, in a more flexible way, and we need to consider what's the patient's chances to be alive in 5 years. This is the point. And it doesn't really matter what's his age now, because as Ronen said correctly, sometimes we have patients 60 years old that have fewer chances to be alive in 5 years. Now, if this patient has a reasonable chance to be alive in 5 years, let's say 60 or 70%, and by the way, this patient, I don't know, I mean, I didn't see him, but this patient probably has the chances to be 90 years old higher than we do. Okay? So we have to remember this point. So I think that if you consider that in his baseline, he had reasonable chances to be alive at 5 years and to enjoy, in quotes, a recurrence with all the consequences of it, I would send the test and address him accordingly. If he didn't recover, and in spite of these repeat follow-ups, his condition remained like this, I think I would do the same as you did. But I think it's a very reasonable management to follow up, because sometimes these patients do recover. Sometimes it takes 2 months or 2.5 months or so on. And this is another point that I need to emphasize, because we discuss difficulties in giving 5FU. We remember that all these patients underwent a very significant test, which is hemicolectomy. Okay, so it's sometimes it makes me quite amused when I hear people say, "Oh, this patient, he could not tolerate 5FU regimen, but he underwent emergency right hemicolectomy or subtotal colectomy without any complications." I don't know. It's something that I cannot, solve for myself so far. And we need to remember it. Our patients, when we see him in the clinic just about a month ago, they underwent a very significant physical testing. And when they stood very nicely in this testing, it's a very major piece of information that we need to consider.
And then I have to confess that the oldest patient I treated for adjuvant treatment was 94. So that's that was pre-oncology.
Ravid, it means that if you're looking for a job in Bellinson, you're most welcome.
Another comments? Another question? Thank you.
The next case will be presented by, who is the next case? Dr. Samir? Okay.
I think that my case is less dramatic. Thank you for the two nice presentations. I have a 70 years old lady with adenocarcinoma. She has good features except of intestinal luminal obstruction, and she has an upper rectum cancer. At this time, we made extrapolation from upper rectum cancer to colon cancer. But now we have the answer that Professor Kozloff presented with the 4th study. We can trust a low-risk rectal cancer, and we can make extrapolation to colon cancer. We have, as you see, a low-risk score, and we choose not to treat the patient. And we have about 3 years, and she is free of tumor until now. Anybody have offered treatment for this patient?
This is one of the more complicated cases. There is an obvious clinical risk factor here. There was an obstruction.
The obstruction, yes.
Is this a clinical obstruction or is it an endoscopical obstruction?
Not clinical obstruction, but in the colonoscopy they cannot
Okay, so that makes a huge difference. So it's not a clinical obstruction. That's why I asked, because
Yes.
we tend to confuse the two quite a lot. So it's not considered an
But it
obstruction.
was,
It's
I
not
think, a serious obstruction that I cannot.
Yes,
they
but,
cannot pass the colon.
But it's not under the acceptable guidelines of obstruction as a risk factor. So in that case, I would support that decision. When you say upper rectum, I'm guessing over the reflection or over 12 centimeters. So, yeah.
I would like to say that using a questionnaire to analyze these patients may be quite problematic. And this is a very good example. Because you say obstruction. We understand by obstruction clinical obstruction and not colonoscopic. The one that reviews the questionnaire doesn't know what you actually said. I would say that if there is obstruction, I would give treatment. And after this low score, I wouldn't give the treatment. So I think that this is not the best way to make a study by using these questionnaires.
Thank you. And Professor Kozloff, you spoke about the grade and the other risk factors, except of obstruction, really, in the 4 previous studies.
I define obstruction as a patient who cannot pass stool, who has to go to surgery emergently. I don't define obstruction as where you can't just get the scope through. As long as the person's having bowel movements, I don't think it's true obstruction. When a patient does have true obstruction, they have to go to surgery emergently. I do treat those patients. I think it's a high-risk criteria. I do not have really great literature to support that, but that's my feeling. Before the study that I just presented, if this was a patient with a rectal cancer, I would recommend radiation for this patient with 5-FU or Xylota. After the study that I just presented, if there was no other risk factors, I would probably totally agree with observation. A low risk T3N0. But again, it's the definition of obstruction that might throw a person off.
And you think and still believe that the clinical data is still important, because we treat with the genetic data, and I believe I trust with this.
I think the recurrence score is one piece of data that you use with everything else. I think one uses their judgment based on the whole picture, and the recurrence score is just one piece of data. It's not the data, it's to be used with all the other data.
Thank you.
I think that this is if there's no obstruction, no perineural, no lymphatic. A true clinical obstruction. I personally, I would treat that patient as a high-risk patient, even though the recurrence score is low. Now, I always was taught that biology trumps everything else, but again, clinical situations you can't get It's just I would treat it as a high risk if there was a true obstruction. It's just one piece of information. You use all the information. If there was a true obstruction, I probably would not. I would recommend treatment. Would I do it out of interest? That's different. I wanted to say that I went through these studies with and my wife said, "What are you studying?" I said, "I'm looking through these studies that I'm going to be presented." And she said, "Are they complicated?" I said to her, "I haven't found anything in Israel that's not somewhat complicated and trying to give a good answer." But But I think this is a great place. And these questions, these case studies are very good to go over.
Thank you.
Good morning. Teva said that we will finish until 11, so I'll do it quickly. My patient is 69 years old lady. She's almost 70. Due to bowel obstruction, subtotal colectomy on January 14, post-operation complications, slow recovery. She also had multiple comorbidities with hypertension, hyperlipidemia, and also diabetes with a little bit of neuropathy. The pathology was T4 with serosa involvement and one lymph node involvement. No lymphovascular invasion, no unknown perineural status. Histological grade 3 and without perforation. Her performance status when I saw was 70%. And she was not very enthusiastic about the chemotherapy. We talked about all the options, and she was in Klalit, so I sent the oncotype, and the recurrence scores was high, with advantage for the oxaliplatinum, and I really wasn't convinced to give her oxaliplatinum, and I wanted to give her only capecitabine, but we discussed it together, and the patient, after she saw the results, she was convinced to take it all. And we started the Xelox, and after the first treatment, she lose it. She was hospitalized in very bad condition, very weak, diarrhea. And after the first course, she came into my office and said, I'm not going on with that, and we stopped the treatment. I saw her yesterday. She's just fine. Her status, performance status now is 90. She's in a good condition now, and she did a CT lately, and she's got no evidence of disease. So this is it. I'm quite. I must say that I did the oncotype, and I hope that we will find out that there is no advantage for the oxaliplatinum, but there was. And I'm a little bit sorry for that I gave her this treatment, because maybe if I would start like I thought with only capecitabine, she might have finished her treatment. She refused after the hospitalization.
I have to say that this is an example again that the biology of the patient is probably should prevail more than the chronological age. This is a true case in which the general condition, the multiple comorbidities should have guided the treatment and not only the recurrence score. Again, this is the catch with having a number, that we need to discuss it with the patient, just like Baruch said before. So once we have a number, we have to face the patients and try to see if what can we do about it, even though it's against the gut feeling of the physician. A very problematic case, and we know.
If I may, I would like to add, because before you said that chemotherapy, as 5-FU Ziloda, is not toxic. You can see from here, and I spoke also before with Dr. Kozloff, chemotherapy, in any chemotherapy, is toxic. And about the Xeloda, my personal experience, I did the first studies with Paulo Hoff at MD Anderson. The Xeloda itself is toxic. And we should consider very well and very much not only the age but the dosage and how you give it. And you don't have to. I'm talking to the people here that because they think that if you are giving something per os, I mean through the mouth, it's very easy. It's not complicated, etc., etc. And it's complicated, and you should be aware to it. And the 5-FU itself, it's toxic. It can cause also MI problems and other problems, and you have to consider it. It's not water. Think about it. It costs less than water, but it's not water.
No?
Can I ask what was the period of time between the surgery and the initiation of chemotherapy?
It was more than 2 months because of a slow recovery
More
from
than
the,
2 or
the
more
surgery.
than 3? So it was less than 3 months?
It was less than 3 months. It was 2.5, I think.
Because we have to remember that patients that have long post-op complications, if they come to us 3 or 4 months after surgery, the benefit of chemotherapy is doubtful. So this is also something that should be taken into account.
She was on the edge.
No, it reduces, but it's not completely, when it's such a high risk.
Yeah, but I think it's an element we have to take into consideration. That's
Yeah, I
all.
agree with you. More question, Danny?
Again, I think it shows that there is a problem to analyze this study by a questionnaire. Because what we would consider from this is that, okay, I upgraded the treatment because of the test, but actually I probably did not have to give this treatment a priori. So it makes the examination, the analysis of the study by a questionnaire only makes it very difficult. And I think this should not be continued in this way, because the data is not really clinical. It's just some impression by a questionnaire.
But it's actually, I don't agree, Danny, completely, because I think this is actually a true case in which we upgraded the treatment against our will.
That's true.
Because of the test, showing that we are influenced by the test. It doesn't mean that we should be influenced by the test. It just means that we are, and that's the whole point of the study. And we're learning as we go how much the test and when it should influence our decisions. So I think this is still. No, I wouldn't give her oxaliplatin and not capecitabine. Actually, just IV 5-FU.
I gave her a full dose. A full dose.
Did you give her neomycin after?
Yes, but I'm sorry for that.
Patient. I mean, maybe reducing the dose properly, maybe she would be better. She's a young woman. She's got very bad prognostic factors. I would treat this patient. I don't know how.
But
maybe for the next time I will start with this dose.
No,
But after I discussed it with the patient and she saw these numbers, she was really afraid from that. And she said, wow, it's bad news, I want it all. So I gave it all.
It's only a few months after surgery. We don't know yet what is our outcome.
Of course. I know.
I think this is a difficult case, and it's clinical judgment. I think clinical judgment, using this as one aspect of making a decision, is the way you have to go. And I could see, depending upon how sick, frail she was, using only capecitabine or no treatment, or if she wasn't that frail when you saw her, using capecitabine or Xelox. I think it's a clinical judgment at the time. I think we've all had patients that we've given chemotherapy to, and they've gotten sick, and we said, why did we do this? And I've seen frail patients in which I give treatments and nothing happens. So it's a difficult case, any way you go. If you didn't treat and disease came back 6 months later, you would feel bad about it.
To Dr. Gev, I would like to say that we question if we should have sent this test. But we analyze according to all the tests, even those that we should not send. So the question, can we learn which tests not to send?
But that's a different study.
Okay, but you cannot put in
the question for the study is if we are influenced by the test. That's all.
You
it's
include in a study.
Question.
You include in a study somebody that should not be included. Come on.
It's a stage 3.
No.
That's the study.
No.
You can decide
Okay,
not. The study is not the design of the study, or the question is not valid.
There are inclusion criteria and exclusion criteria, and you include everybody here without any prior definition.
I have a question about the pathology.
Yeah.
Dr. Kozloff, if I may. What about the mucinous one? The mucinous adenocarcinoma. Mucinous.
I think the T4N1 gives you more information about prognosis than the mucinous. But the mucinous, you might say things are a little bit better because of mucinous, but when you have a T4A-N1, my bet would have been that this would have been a high-risk patient anyways. The question is that you make a decision on looking at the patient clinically, assessing the health, and making a decision on what treatment you want to give. I think the Oncotype DX is an added piece of information, but it's just an added piece of information. This is a high-risk patient. I think I'm making a decision on the T4A and 1 more so than the mucinous.
If it was prostate cancer, you wouldn't consider oncotype colon for it. If it's a rare colon cancer that doesn't look like most of them, why didn't you put apply it?
Again, I'm looking at the stage more than the pathology. But if you said to me, do I have specific information on mucinous, a large quantity of patients where I could validate it in that situation? The answer is no.
Thank you.
Well, a simple case, usual case, 74 years old. He has hypertension, a T3 tumor with 2 lymph nodes out of 29, histological grade 2, no lymphovascular invasion, no perineural invasion, no perforation. The status is good. And the question is what to do with this patient after the risk score is just 26. This is the ideal patient, I think, that I would not give him any treatment or not give him the oxaliplatin according to the what the study, what is the intention of this examination. Still, there is another information that is not on this slide that make me decide to give him oxaliplatin. So what would you do with this information?
Give him oxaliplatin.
Is he in good condition? Is he in very good condition?
90.
Oh, yeah, sorry, can I ask you? So, 74, the age of 70 is sort of, in some of the studies, suggestive of no benefit for
I know,
oxaliplatin.
of course, I know.
So that's the trick the tricky part here, in my view.
I know. This is very tricky, but this is the usual case.
Yes, but I have to admit that if it's in a very good condition, I would treat the patient with full
you
protocol.
would give him?
Yes.
But what about the risk?
Well,
factor?
5%.
So we are asked.
Considered. Again, you consider the results with the patient. If you ask me, 5% is enough for treatment. The difference of 5% is enough for treatment, and yes, in my view, you've asked my view.
So why I sent a test? I didn't want to give him oxaliplatin.
So that's your fault.
That's exactly what the test asks from me. Don't give him oxaliplatin, and
No, that's not
I
what
don't
the
want to
test
give.
says.
Danny, I need to interrupt because you repeat this question several times. The study allows you not to change your opinion. It says if you receive high-risk result, you can say I will not treat as you didn't want to treat before it. So the test, the study is only to see if you're about to change your opinion according to the risk score results, and if you actually did it. That's all.
Okay.
That's all. So and you're allowed within the forms, the questionnaires, to specify that you're not going to change your opinion.
So
that's okay.
Baruch,
and another thing that I would like to say, because you call it low risk, and low risk is a relative term. So you refer to the cutoff of 30, but you see here a 5% absolute benefit from oxaliplatin. So I don't see the point.
So in this case, okay, but this is exactly what I'm trying to ask. So would you send to this patient the test?
Danny,
that's my question.
Danny, first of all,
would you send it?
One minute. Can I answer you? First of all, about treatment. As a physician, you should treat because it's stage 3. Secondly, about if you're going to send the test. If you are doing a study, yes, why not? Because Kupat Cholim would like to,
study.
to do about it something.
Clinically?
Clinically, no, I wouldn't send the test.
Baruch, would you send this test for this patient?
Yes, I would send it first of all as part of the study,
Okay.
but aside of the study, also in the clinical practice, because it will provide me also additional information, as I referred before, as how many cycles I may give with oxaliplatin, or maybe if he will run into very significant difficulties, how much I will insist on completing the 12 cycles of Folfox. So I would send the the test anyhow.
First time that I hear such a thing. What does it mean? What does it mean that you
there
have
is
to give him
a low
adjuvant,
risk,
you give him adjuvant.
but this is exactly what we expect.
I give him adjuvant, but if I get a result that maybe oxaliplatin has a benefit of, let's say, 2%, okay? I will go to the extreme, maybe only 2%. I will feel much more comfortable, for instance, to offer this patient 12 cycles of Folfox, and in the last 2 cycles, I will not give oxaliplatin, and will reduce significantly the risk of peripheral neuropathy.
What is the data to support your...
No, the cumulative dose in the flux regimen, is less.
I wanted to send... I wanted not to give this patient oxaliplatin. That's exactly our aim.
No, this is your aim. This is not my aim.
So that's the aim of the test.
No, this is
to find the patient who will not get...
Danny, nobody says to you what you need to decide with the test. This is just a descriptive prognostic test that gives... What do you mean? It's like not asking the grade. It's like not asking if there was a perforation. You want to have all the clinical data available in order to make a decision. So if you have perforation as one of the factors, if you have perineural or lymphovascular invasion as one of the factors, you have an oncotype as another factor. It's another prognostic factor that allows you to have a more educated decision.
So Baruch says in any case that with it or without it, he will give the oxaliplatin, yes or no, with less courses, but he will give it. I wanted to find the patient that I can avoid the toxicity of oxaliplatin. This is what the patients that promote this test claim.
But he told
we want to find those patients that will get less oxaliplatin, less toxicity.
Danny, I agree with you, but as a physician, stage 3, I think that you should treat him. And also you added here that he had a large peritumoral lymph node.
I'm trying to understand. No, but I'm trying to understand what I learned from this test. what I learn from this test? I pay so and so, and what my patient gets from it.
But we don't have enough experience yet to say that. That's exactly what I've told you before. I think we are still learning. I think we know for stage 2, we're very confident with the test in stage 2. I think we're very still premature with stage 3 to really say when or which subtypes of patients would really influence the decision. I think we're still learning. It's fine. It's fine.
So now tell me, therefore then tell me, how can I learn from similar studies, from 1,000 similar studies, how can I learn what was the true,
we can redesign the study, Danny.
That's what I
Just
want. That's exactly what I want. That's exactly what I want.
We can
redesign the study.
But there is another question that you can
That's
ask.
exactly what I want, to redesign it, because the way it is now, it's going to nowhere.
But it's nothing to do with what we're talking about.
The study you have, the study you're asking in stage 3, is that will this test change what you're going to do? And in this situation, the answer for you is no.
Why? But,
so it does give us information.
But I have 1,000 patients with 229, two lymph nodes, and all of them are 26 low. So I will give them treatment or not. What I'm going to do now? Help me, please.
But
help me.
The answer is that if you told me you were going to treat this patient before Oncotype DX with Fofox or Zelox,
That's what I thought.
My answer is it makes sense to me. And if you told me after you did this test that you were still going to treat the patient with Zelox or Fofox, it also makes sense to me because there's a 5% benefit. But there could be, I can give you other situations in a stage 3 patient where you may want to change your mind. Let's say this is a 60-year-old person who's how many surgeons are here? You make your living with surgery, right? What happens to you? What would happen to you if you weren't able to do your surgery because of bad neuropathy? Would a 5% benefit be worth it for you possibly not working the rest of your life? Okay. Wouldn't you want to know, would you want to come to an oncologist who would say to you, take Fofox and you have no choice? Or would you want to go to an oncologist who would say, listen, I can give you this extra drug. It'll give you a 5% benefit for cure. However, there is a 15 to 20% benefit downside that you may never work as a surgeon again. There's a situation where it can be helpful.
I think we will conclude with this. Thank you so much. It was really productive, interesting. Good Shabbos. Thank you.